you everyone for being here. So this is a joint event organized by the Center for European Reform. We are an EU-focused think tank, and jointly with WifOR. I'll introduce our speakers in a second, but Dennis is here on behalf of WifOR, and we're really excited to have all of you here in the room and to have many people listening online. So I thought I would just say a few words on why we thought this this event on EU fiscal policy, our public health investments, a no-brainer choice, is because the EU just launched a new system of fiscal rules to govern budget policies in member states. And it is in many respects a fundamental difference to the old rule system, which had sort of annual accounting logics of sort of tough spending limits. The new system is different. It's much more long-term. So member states submit multi-year fiscal structural plans rooted in an analysis of their debt sustainability and their long-term trajectory of public debt. And they can get extra leeway from the European Commission and the Council eventually if they commit to growth, enhancing reforms and structural sort of measures. And that matters a lot. And I think that was part of the logic of the reform, is because Europe is an aging continent. We have a long-term shrinking workforce. And so one of the big questions here is essentially, how do we keep the health of this more scarce workforce high, in the sense that people can have long, productive lives, which also matters again for fiscal sustainability, because that's, of course, linked to tax receipts. And certain types of health investments, we know from the literature, like vaccines, do not only save many lives, but they have a fairly hard to beat cost-benefit ratio, right? So usually public investment, you think of a 3 or 4% annual return. If you look at a recent study on a strep A vaccine, for example, a 60 billion investment is estimated to lead to 1.6 trillion return globally. So that is, if you annualize that over a 30-year cycle, is a return that's much closer to like 14 or 15% a year. So the question really that we had today was, we have this new fiscal system. And so how can member states in the EU, but also the UK, European countries more widely, how can they prioritize these types of health investments? Which ones should they prioritize? And does the European system, both these rules, but also the European budget and the recovery fund, do they cater sufficiently to these types of health investments? And I'm very excited to have a really, really excellent panel with us today. So let me briefly just introduce the panelists. There's Grace Hampson, who's Associate Director at the Office of Health Economics, which, fun fact that I learned today, is the world's oldest independent economics health organization. We have WifOR's Institute, again, our co-organizer, CEO and co-founder, Professor Dr. Dennis Ostwald with us. We have Santiago Calvo-Ramos, who is a European Commission official specialized in this topic. And Margarida Marques, who was the co-rapporteur in the Parliament in the last cycle on the fiscal rule reform. So we're really excited to have you here with us. And finally, Hatice Küçük Beton, who is the Executive Director at the G7 and G20 Health and Development Partnership, to give also a bit more of a global perspective on these issues and Europe's role in the wider world. So I will stop blabbering on, and I would like to turn now to Grace to give us a sense of the sort of academic cutting-edge literature on these issues. So where do you see the health challenges in the UK and Europe? And how do you look and think about health investments as a researcher and expert?
Sure. Well, thank you very much for the introduction, and thank you for the invite to be here. So I've been asked to talk about, or to set the scene, I guess, in terms of the description of the health challenges in the UK and Europe to start off with. So I'm going to talk about 4 major challenges, and this is not an exhaustive list. It's just to give you a flavour of the sorts of things we're up against. So the first one is the devastating impact of major risk factors. I'll talk a bit more about that in a second. Health inequalities, population ageing, and the fourth one is challenges with health systems themselves. So first one, risk factors for ill health. So unsurprisingly, smoking, poor diet, lack of physical activity, alcohol use are the leading causes of preventable ill health and mortality. That's in the UK, but also Europe more widely. It was reported that 78%, that's more than 3/4, which is quite staggering, 78% of adults in the UK have concerns about their health, with the biggest ones being mental health, weight, physical inactivity. So this is really unsurprising, but still quite shocking in that we know that this many people are concerned about their health. And to make this worse, and linking to the next point around inequality, all of those risk factors are correlated with social and economic status. So we know that in the more deprived neighbourhoods, there's less access to healthy food, there's less access to green space. The environment is just not set up for people to look after their health. The type of work doesn't facilitate them looking after their health. And all of these correlate with those risk factors. So moving on to talk about the health inequalities are widening, which again is shocking. In, it's state-of-the-art era that we live in, health inequality is getting worse. In England, to give you a flavour, there is a 20-year gap in life expectancy between the most and the least deprived areas. 20 years is really staggering. The third one, population ageing. So people are living for longer. That trend is actually stalling, but still people are living longer now than they were before, but they're living with major health conditions. And again, this trend is set to continue. By 2040, it's estimated that 1 in 5 UK adults will be living with a major condition. So what we really need to be looking at is extending healthy life expectancy, not just thinking about life expectancy. And the fourth challenge that I want to mention is challenges with the healthcare system. And again, there's lots of stats about it in the UK, but this is not European or, it's a global problem. Health and social care systems are already struggling to deliver to the healthcare demand that exists. And we've seen from the stats I've just given you that, the demands are increasing and are going to continue to increase over time. Waiting lists are at a historic high. Staff shortages are rife. The staff that we do have are reporting really high stress, high burnout. The estate is physically crumbling. The infrastructure is just not well maintained, and systems, so support systems, admin systems, IT systems are slow, outdated, and just often not fit for purpose. These problems with the healthcare system translate back into health problems via long waiting lists, a lack of preventative care, late diagnoses. So it's not just a problem with healthcare, that translates into worse health as well. And across all of these 4 challenges that I've mentioned, it's not just the individual's health that's suffering, but we know that for government and wider society, we're facing stagnant labour productivity, stagnant economic growth, and a sick workforce. We're paying out, more in sickness benefits than we have done before, and it's a real challenge for government. So it gives you an example and illustrates how challenging that health environment is now. Sorry, that's a little bit depressing. It's going to continue being depressing for a little while. I'm just going to talk a little bit about how health investments can alleviate some of these burdens. So much of our work in this space has been in the prevention space. That's what I'm going to talk about. So we've demonstrated that prevention is a smart use of public funds and also private funds, if you think of like employers and even, paying for your own exercise. So prevention is cost effective. Investing in prevention is 3 to 4 more times more cost effective than investing in treatment. It offers good value for money. There was a systematic review and meta-analysis undertaken that found that public health primary prevention programs have a return on investment of more than 14 to 1. Prevention is obviously good for the individuals. It's good for business. We have a record 2.5 to 25 would be a bit different. 2.5 million working age people inactive in the UK, which means that the labour market is really tight. Obviously, prevention is good for the health service. Not only is there capacity constraints, that means that we're facing unprecedented demand, but also there's a huge amount of unnecessary spending on preventable conditions. By some examples, I've got 2.5 billion a year on smoking-related conditions, 6 billion a year on obesity-related conditions, and 3.5 billion on alcohol in the UK alone. So these are huge figures that we don't necessarily need to be spending if we can get the prevention figures right, the prevention policies right. Prevention and preventing ill health is also good for governments. So preventing ill health can increase tax receipts, reduce welfare payments, and generate savings also to police and the criminal justice system. And also it's good for society. Lost productivity in the UK from preventable ill health is estimated to be at 70 billion per year. just to give you an example of how healthcare interventions in the prevention space can alleviate these figures, we did some analysis around the return on investment in vaccines, and I know Dennis is going to talk a bit more about their research in this area. But one analysis we did found that adult vaccines can return up to 19 times their initial investment to society. So that's when significant benefits beyond the health system are monetized. So it's, you know, the return on investment here that's up for grabs is really staggering. I've got some challenges. Have I got time to talk about the challenges, or am I? Yeah, okay. So in terms of challenges on how we take investing in health forward, just to carry on the depressing note, I've got 3 key challenges that I'm pulling out. So the first one is that health is not just determined by the health system. It's kind of an obvious point, but those wider determinants of health, social, economic status, you know, housing, the commercial and economic conditions that people live in are key drivers of health. And so if we're really serious about investing in health, we also need to invest in the wider determinants of health, which is very complex and very challenging. The second challenge is that the wider benefits of health in terms of getting people back into work and those increases in productivity are not considered in programme evaluation, even within the health sector. So we're missing out on capturing those wider benefits, and we're not highlighting those wider benefits for governments and for society. And then finally, and some of the fellow panelists and I were talking about this just a moment ago, is that the investment that we do see is often focused on short-term goals. So if you think about that prevention, the prevention example, and how investing in prevention we know can have a huge payoff later down the line, the payoffs are in the medium to long run. They fall outside of the immediate budget cycles, they fall outside of the current political cycles, and therefore they're just not as appealing to invest in at the moment. I do have some notes on solutions, but I think we'll come to those later.
Thank you so much. I think the new Labour government would be very excited if they had 12 billion extra a year, if not more. But these challenges you describe, I think, are very typical also for European countries, including low productivity growth. There's a huge debate in the EU currently about our anemic growth rate, and so it seems highly relevant. I think on that note, Dennis, you've done a lot of work on the return on health investment. You've presented in many places around the world, so maybe you can tell us, you know, a more optimistic story about where we might go based on what we know. Thank you.
Okay, thank you so much. And thank you, Grace, for this great insights. Happy to be here today. And yeah, I want to explain a little bit more why investments in health is a no-brainer. And it's a no-brainer if you have a straightforward narrative. And this is important. I'm often still shocked if you consider what happened COVID-19 and how politicians now act concerning health investments. It's crazy. We still have COVID. The next pandemic will be there, and we haven't learned. We haven't learned out of it, and we need to learn to be prepared for the future. And therefore, first of all, we need to see health not as a cost, but as an investment. A public and private investment. Second, if we are talking about investments, we need to give evidence to the return on investment. And there are a lot of examples, but it must be in a very structured way. Not only use cases, but you need to analyze the entire health investments. And therefore, you need to develop a health metrics, which you can embed in the youth semester, or you can embed in other households, where you track and monitor what is the return on investment year by year, due to which intervention and due to which investment. And I will explain to you how we and our colleagues of us would suggest to measure return on investment. But then, even though, and I was in Brazil, I was in Mexico, and everyone says, yes, health is investment. But then the question is, who is financing it, right? Even if you have a high return on investment, you need to ask someone for money. and so you need to convince someone to see it as investment and invest in it. And there are four ideas as well. Coming back to the health metrics. First of all, we need to understand that there are three major layers. First, the health investments create GDP and employment. That's the so-called economic footprint part, and fiscal tax revenues and so on. You can easily calculate what is the return on economic investment. What is the return on investment in economic terms? And just an example, the entire health expenditures, investments in Europe create a GDP which is comparable to the GDP of Spain and Estonia together. So we were talking about this, it's close to 10% of our wealth. Now imagine we would invest 1% point less in health, most of the European countries would be in a recession. Right? So in other terms, if we invest smart, we are stimulating growth, we are stimulating employment, and we can start a positive feedback loop. The labor market effect, then due to the health investments in Europe, is comparable to the entire labor force in France. 30 million people are employed only in the healthcare sector. So these are economic facts. You can also analyze exports and imports, and you need to place health as an economy, as a sector, as a macroeconomic sector of Europe. The second point is, and that's what you already mentioned, we need to start to measure what is the impact of investments on human capacity, on the individuals. We are facing labor market shortages all over Europe. We have aging population. We can't afford ill people. We need to invest smart so that we keep them healthy, productive for the labor market, so that they can pay taxes. And then we have an additional return on investment, right? Next to the economic impact, we have kind of a social impact of health investments. And the third one is that we need to start to think about where to invest in health. And I would suggest that we should keep an eye on the highest cost of illnesses. The socioeconomic burden, which is different in all European countries, in Latin American countries, different. Sometimes cardiovascular diseases are killer number one, sometimes cancer. And then we need to start to tackle this high burden diseases. And just an example, cardiovascular diseases in Europe creates a productivity loss, a damage, which is comparable to 4.2% points of our wealth. So if we would start to prevent cardiovascular diseases, then we can calculate how much can we decrease the socioeconomic damage. And this is productivity win then, right? And then we have the third layer. Now coming to the, and this matrix can be embedded easily. It's not very complex, but you can scale it up and compare it between different countries. How to finance it? First, we need to start globally, but also especially in Europe, to analyze where we invest within the healthcare budgets. Is it smart to invest in hospitals? Is it smart to invest in prevention? Is it smart to invest in early diagnostics? So it's not in all countries we need to invest more in health. No, we need to invest smarter in health. The second is we need to start to convince, out of the health bubble, we need to convince ministers of finance, other policy makers, that maybe some budgets which are invested now in infrastructure, in defense, in education, if there is room to reallocate it to health, that could be a second mechanism to finance more health investments with the evidence. And we need to compare return on investment in education and health and something else. The third mechanism is, in my opinion, we need to convince the European Investment Bank or other institutions that they may co-finance health investments, right? And globally, that multilateral development banks create support investments in health, because it's a no-brainer, because there is a return on investment in economic terms, in societal terms, in reduction of disease areas. And the fourth is, that would be the game changer. We try to convince rating agencies that they should consider this health metrics, because if we can promote that if a country invests smart in health by using evidence to point out that there is a return on investment, then the prosperity of the country should increase and rating agencies should consider it. And if you talk to a minister of finance and you can tell him, if you do it 3 years, this investment plan in health, and you get a better rating, then he can more easily refinance his debts in the future. And then we have a mechanism which really creates a better platform and smarter investments in health. Thank you so much. I'm looking much forward to the discussion.
Thank you so much, Dennis. We just heard from 2 researchers, and I wanted to turn now to Santiago, who works for the European Commission. He's joined us online. Santiago, you're an expert on health, but also on fiscal policy. And sort of, if you listen to what these researchers have to say, how are you thinking through this as the Commission? How are you going to look at these budgets from the member states that are coming in under the new rules, and how will you think about, you know, the kinds of questions that that Grace and Dennis have pointed us to?
Thank you very much. Yeah, no, I mean, I think these are very interesting contributions. I mean, it is something that those of us working in healthcare for a long time have heard a lot, and it's something on which I think there's actually quite a lot of consensus that prevention is very important. But okay, so to bring this back to the fiscal rules, and what are the new fiscal rules, and what do they tell us about health investments, and what is the way forward? I can tell you a little bit about the fiscal rules and then go on through the rest. So the new fiscal rules entered into force on the 30th of April 2024, and they're basically a new way of assessing whether member states are in a trajectory to meet the Stability and Growth Pact rules. The Stability and Growth Pact rules remain the same. They are in the treaties. It's basically the limit of 60% of GDP for public debt and 3% of GDP for the deficit. But what really changes is how member states are expected to meet them. So starting this autumn, all member states will be asked to prepare a national medium-term fiscal structural plan that will basically contain a number of fiscal reforms and public investment commitments that over 4 years should ensure either that debt remains at prudent levels, or that it remains on a plausible downward path, or that it is put on that plausible downward path. And member states can request extensions of the adjustment period up to 7 years if they propose in their plans reforms and investments that they can say will support this improvement in fiscal sustainability and are growth enhancing, address common EU priorities, such as those expressed in the country-specific recommendations. So basically, compared to the previous system, very much as Anders said, there's a move from a focus on the 1 year to a more long-term sort of perspective. And there's also a greater emphasis on investment. Now, in terms of how this will affect investments on healthcare, on public health, prevention, etc., public health investments and reforms will be assessed in a similar way to how national policies are assessed in the European semester. So for each member state, we will look at the available indicators, review of the literature. We will discuss with the authorities and with national experts. And then it will be quite different, very much as Dennis was saying, you know, what are the main priorities for each member state? For some of them, the big priority may actually be accessibility or adequacy of healthcare, or simply poor health status of the population. And in that case, the focus will be on how these issues can be tackled, mostly through additional expenditure, investment, or reforms where necessary. For countries with fiscal sustainability concerns, the focus will be more on improving the cost effectiveness of healthcare. And I'd like to spend a little bit of time discussing this because it's often, you know, people sometimes just say structural reforms, and it's almost like it could mean anything. So that's why I always like to give specific examples. So I'm thinking of things like effective budgeting, governance, and control, ensuring that budgets are realistic and that they're met. It's very difficult to actually meet budgets in a healthcare system because there's always a degree of uncertainty about the level of demand you are going to encounter. So it's very, very difficult to avoid budget overruns. And so good budgeting practice should be implemented so that the right incentives are given to the managers, but also we can differentiate between good and bad performance. Similarly, it's important to benchmark performance both at national and international level. It's very difficult to know how well you're doing things if you cannot compare to anyone. But of course, this requires investment in data. So having all the indicators that you need, and also having a good institutional setup, which also requires investment, and a sort of a good governance structure that allows for then good performance management once you have benchmarked that performance. Then, of course, rebalancing from hospital towards primary care. It's actually much better for patients, but also cheaper if we can manage conditions at primary care level before they escalate and require hospital care. This happens with something like diabetes, where actually it's relatively easy to keep people well managed for a primary care doctor than actually dealing with complications that mean that these people actually need hospital care. Similarly, prioritizing prevention and health behaviors. This is something that the two academics have explained very, very well before me. This is something that is very important and that is sometimes difficult to make political national authorities or even healthcare managers, healthcare system managers realize. Then, of course, we need to ensure that when we purchase pharmaceuticals and other medical supplies, that we purchase them in a cost-effective way. So we get value for the money that we're spending. And then workforce planning is a huge issue now with lots of shortages in healthcare staff all across the EU. So workforce planning, looking ahead, is extremely, extremely important to ensure that we have an adequate number and mix of doctors and nurses. Now, when I think of particularly successful examples with health investments in the EU, as you all know, the Resilience and Recovery Facility is EU funds that have been provided to EU member states as part of the sort of the funding made available for resilience and recovery. There has been a lot of expenditure on digitalization of health services, which can be very helpful because it basically can really help you identify the same patient by different parts of the system, and that the system can really work around the patient and everybody holds the same information. But for me, there are some investments that have been made in places like Czechia, for example, to strengthen cancer screening and to create a center for cancer prevention at the Masaryk Oncology Institute that I think is quite inspiring, because it's the kind of institutional center or institutional change that can in the future lead to better prevention policy. And similarly, they also funded a research and development consortium on diabetes and obesity. So these kind of things that connect to prevention, I think, are quite good. And similarly, Horizon Europe has been investing a lot in vaccines and a lot in innovation that I think actually can be really useful for the future. So in conclusion, the new fiscal rules allow for more gradual adjustment, more ownership of reforms, because they will appear in these national plans. And it also recognizes the importance of investment more explicitly. So I think it can encourage more investment from EU member states. Within this new framework, healthcare investments and reforms in national plans will be assessed in a similar way to how they were assessed in past semesters, taking into account both challenges of accessibility and also the fiscal sustainability of healthcare systems. So yeah, I hope this answers the question to some extent and contributes to the discussion. Thank you very much.
Thank you, Santiago, for your excellent remarks and for giving us a sense of the thinking from the Commission side. I wanted to turn to Margarida, who, as a member of the European Parliament in the last cycle, was very much involved with the new fiscal rules, and you helped to negotiate them. difficult as that was. It's probably one of the most difficult files to negotiate in Europe, in fact. So I'm curious how you reflect on this health dimension specifically.
Thank you very much, and thank you very much for the invitation. Yes, I'm a former MEP. I'm no more member of the European Parliament because the leader of my party decided to replace all the 9 Portuguese socialist MEPs. So it's why I'm not an MEP as it is in the program, but a former MEP. As Sander said, I was the rapporteur for the revision of the fiscal rules. It means regulation of the European Parliament and the Council on the effective coordination of economic policies and on multilateral budgetary surveillance. So it means that, as Sander said, it was very difficult to change the framework because 2 different reasons. Because, as you know, normally is a very tricky and difficult subject with very different positions from the North countries and the South countries. We need to go back to sovereignty debt, the 2007-2011 crisis to understand this difference. First, and second, we take the decision in the Parliament during the last plenary before elections. So it means that it was very difficult with these 2 new elements, because of course it was difficult. On the discussion of this subject, I'd like to raise 3 points. The first, does the EU's new fiscal framework sufficiently cater in public health as a critical investment? And I think that is a main question for this debate. A second point, the EU role on health policies, the EU Health Union. And third point, the EU financing to health. On the first point, of course, if I want to answer to this question, my answer is yes. My answer is yes, and those who said directly, without go to the concrete examples, no, they are whitewashing national policies, because in my view, the key point is the political will. The national political will. Of course, if there are a national political will, the health policies or the health politics are a priority to the member state. So this is very, very, very important to understand, because the new framework is more flexible, more ownership, as the previous speaker said. So it means that it's given to member states more capacity to transpose the political will to the national plans. So we know we didn't change the treaty. The 3% for the deficit and 60% for the debt are still there. We didn't change. What we change is the way to achieve these targets. And there are more flexibility than before, and it's clear, it was already clear before COVID, but during COVID, it was clear that the economic governance framework, the current economic governance framework at the moment was not acceptable. By the way, the Commission decided to suspend all the economic governance framework during the COVID crisis, because of course, if the economic governance framework was in force, member states couldn't have done the investments that they need to do on vaccines, on research, support families, people, firms, and so on. So, but we need to say that before COVID crisis, Commission had already launched a public debate on the revision of the economic governance framework. So this is important also to say. And to go back to the title of this point. Of course, we know that the organization and the financing models of the public health systems are different from one member state to another. So when having in mind what we said on investment, of course, this is very important. And we need to look to the different situation from one member state to another, how member states, how governments, how the state support citizens or finance citizens to accede to health services. Is a public system where citizens go directly to the public institutions and so on, or is private and financed later on? There are different situations from one member state to another on the organization and on the financing model. But also the fiscal stance is different from one member state to another. Commission last July decided that seven member states will enter in excessive deficit procedure because they didn't respect the situation. But we need to say that now, with the current situation and with the current framework, by the way, that entered in force on last 30 April, there are more flexibility and gives more room of maneuver to member states to invest. So, as I said, what is important is national political will. And I need to say that last 21st July, the Commission sent to the member states one by one the reference trajectory. It means how must the member states can increase the net expenditure, increase or not. And also the member states must present the adjustment plans until 30 of September. It means that on the negotiations and on the relations between the Commission and member states can give to health a priority, as I said, if there are a political will. And these national plans means the reforms and investments that member states can do or wanted to do for the next 4 or 5 years. And it's also important to remember, and it's something that is there because the Parliament demanded this position. It means if a member state makes a big investment, the member state can demand to prolong the national plans for more 2 years. So this is a new rule that was demanded by the European Parliament. So it means that on the national plans, member states can integrate the investment and the reforms that they want to do in the health system and integrate it in the national plans. So we need to understand also that this negotiation with the Commission, this reference trajectory, is based on the calculation of the net expenditure. And the net expenditure calculation is based considering out of this calculation the interest expenditure, the discretionary revenue measures, the cyclical elements of unemployment benefit expenditure, the one-off and other temporary measures, and also the co-financing for EU funds. That it's not considered in the net expenditure calculation. And this is also demanded, had been demanded by European Parliament. It was very difficult. It was a last-minute agreement. I know that the Commission is not so happy with how to deal with this new principle, but this is very important namely for the member states where EU money is used, for example, on a health system, not only on research, on the construction of health unities, hospitals, and so on. So this is more important for the member states that are the most beneficiaries of the EU funds. Because we know that in the previous multi-annual financial framework, sometimes member states couldn't use the money because using the money, the co-financing, it increased the debt and the deficit, and they had the money, but they couldn't use it because the calculation of the deficit and the debt. And we could have it last minute, 1:30 in the morning, 1:30 a.m., but we could have this without ceiling. So this is also very important, and very important for the health systems. My second point is on the role of the EU role on the EU health policies. Can we speak on EU health policy, EU health union? Can we speak on this principle or not? After COVID was the best moment to have it, as we had during the British presidency, the EU energy. Because after the addition of the new countries, Poland, for example, and Russia cut the gas supply to Poland, and it was a big energy crisis. I'm speaking a long time ago, so more or less 20 years ago. And at that time, during European Council in United Kingdom, during the British presidents, they decided to create a EU energy union. So some progress were made, not enough until now, but of course, COVID, was the moment to go ahead with the creation of the European Health Union. I know that we could have more progress during a Health Minister Council, but it was not so, they couldn't have so much consensus to go ahead with the creation of the European Health Union. But it's clear that we need, first of all, one health. It means human, animal, and plant health are interconnected. We know that they are interconnected, and we need to look how we can work in different policies to respect this interconnected situation. So it means that in practical terms, this means that factors such as animal health or our ecosystems, the climate, the quality of our air, and chemical released into our environment are all key considerations when we talk about health. And when we look to this situation, we can understand that EU can and must have a role when we look to the different policies, because we have an experience. It's not the EU Energy Union. It's also, for example, when we look back in the progress in the construction of the European Union, we can understand, for example, how gender balance progress, how environment policies progress, because 30 years ago, environment was not in the EU policies, and we could do with developing these policies like gender balance, like environment, as horizontal policies. So it means that to have this interconnected approach, we need to work in different policies, and we must do it at European level. And we know also that research in rare diseases and so on, it's also more effective at if they are done at EU level. And I'm looking to the time, but we could raise other arguments to justify that we can and we must be stronger on the European Health Union, because there are different dimensions that are more effective at EU level than national level. But it's not enough to say we want European Health Union. We need to find the tools, to find the instruments that can help on the construction of this European Health Union. And EU for Health is a key tool, is a key element, a key instrument to pave the way to a European Health Union. And the creation of this EU for Health program is a clear message that public health is a priority for European Union. We know that this program was created after COVID-19 because it was clear also during the pandemic that the national health system had a lot of fragilities. And also the EU for Health strengthens the common mechanism that can reduce inequalities in health and instead promote better access to health care and contribute to the creation of the Health Union. So, and now finally, I move to the last point, the EU financing. And on EU financing, we have two main instruments. By the way, I was a rapporteur for the multi-annual financial framework and also member of the RRF working group, Recovery and Resilience Facility working group. On the EU financing, we have two dimensions. One is on MFF, multi-annual financial framework, the current one, 21-27. The main program, as I said, is the EU for Health, and health is an investment, and the financing of this program is 5.3 billion for the period 21-27. And this is an unparalleled EU financing support in the health area. And I need to say also that the Parliament could give a budget 4 times more than the Commission proposal for the EU for Health program. And it's justified because it's EU for Health brings an EU added value and it complements the policies of the member states. But also in MFF, there are other programs where the target is not health, but health is the beneficiary of the programs. For example, with Horizon, as I think you or the previous speaker already mentioned it means Horizon can give a key contribution to health development and research, that health is a beneficiary and health is a priority in Horizon program. And the same with the European funds, the European Social Fund, the Regional Development Fund, the InvestEU program, the BEI, the European Investment Bank also. So it means that in the framework of MFF, health is a priority and the EU money can be used to improve the health capacity, the health system in the member states to deliver better service and better support on the prevention and on the health systems. Finally, the Next Generation EU. Part of the Next Generation EU, as you know, the Next Generation EU is a fund that was created after COVID for relaunch the EU economy, and member states might prepare national plans to recover and resilience facility. And there are 6 priorities. One of them is health and economic, social, and institutional resilience. Improving the resilience, accessibility, and quality of health and long-term care, including measures to advance their digitalization, increasing the effectiveness of public administration systems. So it means that this is a priority of the RRF, and member states used part of the money on this priority. Now this was launched 2021, so maybe is the moment to assess how European Union money is used to improve health system since 2021, because as we know, next June, the Commission will put on the table the new MFF 28-34. So the new MFF, so it's very important to understand how the EU money is contributing to improve the health systems and how it can be considered for the next MFF. Thank you.
Thank you so much. Excellent overview. I'm really happy you spoke also a bit about the European instruments, which we hadn't covered so much, and I think it's very important. You also really made a convincing case that there are spillovers between countries, which is why there's a rationale for European action. I think that's a good segue to listen to Hatice, who works more at the global level on these issues. So Hatice, please tell us a bit what you see more from Europe's role in the wider world and vice versa.
Thank you so much. First of all, let me highlight, when I joined this call, I didn't guess that there will be so much linkage to the UK still being considered in a way under the EU discussions. So as a European sitting in London, it's music to my ears. And we hope we bring the UK back to the EU sooner or later. Coming to the G20 framework. So obviously as the G20, G7 Health and Development Partnership, we've been over the last 8 years actively engaging to bridge the miscommunication and dialogue gap between health and finance ministers. And our prime goal, as Dennis and others know in the room, was to basically show to health and finance ministers that health is actually a positive investment into the economy. And while saying that, we always knew that the EU was always a step ahead in making that argument and this case. However, as many of you outlined in the conversations right now, is we helped over the last few years, just in 2019, to establish the first G20 Health and Finance Ministerial Dialogue. But thanks to the pandemic, ironically, we basically received a lot of more political support from finance ministers who started opening up their doors and listening to us that health is actually an economic case and spans across many other budget portfolios than just the health minister's budget portfolio. And a few areas were mentioned by Santiago earlier on. Occupational health, for example, is an area the budget doesn't really come from the health ministry in every country. So the question then emerged in the G20 discussions, where do these budgets come from? And even if you think of the during the pandemic, when the EU did the pledging conference with the ACT Accelerator, not all the money came from health ministries. So that showed us there's so much more budgets to be unlocked horizontally when we have a structured dialogue between ministries in countries. And coming to your point earlier, Margarida, it is political will, and we have shown that during the pandemic. So in order to look into where the EU's role is within the G20, I must say, having been engaged in all the G20 health ministerial dialogues, the EU had always the strongest economic argument to make. I mean, not only is the EU or performs 1/6 of the world economy, they're one of the major trading partners or blocs within the G20 as well. And when it comes to the health portfolio, the EU was always leading in their approach. And if I look back a few months ago, when I started this initiative also with Dennis, looking 2 years back, actually, we had many dialogues in the European Parliament where we said, how can we embed into the European semester a more structured, like, dialogue where we embed health metrics. And as Dennis said, these metrics are there. They can be implemented into the semester, and we can help countries to report more on their health investments within the European semester. And now with this fiscal reform that Santiago mentioned, that gives countries more of a long-term planning and purpose. And yes, we face in the world, I mean, half of the world's population is trying to service their foreign debt right now, and we're in fiscal turmoil. But with these longer plannings, at least we can educate countries to say, look, it's not an issue to have debt. You can basically invest in health. You can acquire more debt, but the long-term benefit, return on investment and value will be X. So we need to tell them this economic argument. And if you look right now at the G20 level, where the EU is actively engaged in the G20 platform right now in Brazil, but the initiative started 2 years ago in Indonesia, we have the Joint Health and Finance Task Force, where health and finance ministries regularly come together and talk about health vulnerabilities and how they can basically structurally invest into certain areas in the health system, not in disease silos, in the health system as such. And in the G7 platform, now currently led by Italy, you have the III initiative, which was created a few months ago. And they look at new ways of investing into health and how we can bring basically, as Dennis said earlier, regional banks and development finance institutes into a dialogue to structurally invest into health. What we have done concretely as the G20 partnership is, while we always talk amongst each other, be it in the G20 platform or in this distinguished panel, it's very hard to, and Margarida maybe will join me in this, it's very hard to convey the message to non-health policy experts within the European Parliament, so they understand the value of investing into health. And by looking, for example, at this year, what we have done is, this year was a big, or is still a big year for antimicrobial resistance, AMR. So we took the liberty to develop a legislator's report, for example, with a number of parliamentarians representing their parliaments. And this legislator's report we circulated to the G20, where we outlined the key economic challenges that AMR, antimicrobial resistance, is causing onto the entire ecosystem. So Margarida mentioned the One Health approach. So we wanted to increase the awareness and support by finance ministers, environment ministers, and agriculture ministers as well, what it means if they do not contain the rise of antimicrobial resistance in their poultry farming, for example, or in their water management. And with that, we realized by embedding the structural dialogue and bringing parliaments into the mix, we got more traction, and parliaments started to put their governments or hold them more into account. And looking back again to the European level, what we had suggested with Dennis a few months ago is, why don't we have a structural dialogue every year? I mean, there's obviously European semester debates happening in the European Parliament, but why don't we specifically talk about the role of health investments within the European semester in the short and long term? And why don't we have parliamentarians to hold the Commission or the member states, the Council, into account? And let me say this, one of the things we always say in the G20 level is, it's not a no-go to basically to have a structured or different dialogue also with businesses or the pharma industry. It is okay if health is a profitable exercise as well, as long as it's been done ethically and it basically benefits the populations. So I think that's from a G20 perspective and the work we've done that I would like to add into. And on a second point, I would like to highlight that in terms of the whole area of governance, we are seeing increasingly, triggered by the World Health Organization, that there is more of an effort of countries like looking at Norway, Sweden, Australia, even Saudi Arabia. They're implementing a health in all policies approach. And the health in all policies approach is a new governance mechanism that brings together different ministries and they basically identify between ministries what it takes to improve health systems or the health of their workers by putting more money into prevention. And by embedding it into the ministerial governance structure and KPIs, each ministry basically reports to the Health in All Policies Collaboration Center. And that way you can see how different entities basically are contributing to the health. The other thing that we've been actively vouching for the European Union to look at, or also for the current government in the UK, is the trade unions. For example, if you remember during the pandemic, we spoke about investing more into health. We tried to gather the funds, all of us, but there was little dialogue with trade unions. And if you just look at the prevention component, there could be a use case where we could say, let's work strategically with a trade union and use one or two businesses or factories as a use case, and collaborate with the trade union to do regular screenings in basically factories for the employees. And by doing that, like every 6 months screening of employees, as you said, Santiago, a short-term cost or investment into prevention and screening will actually help us to prevent a long-term cost of hospitalization. So the trade union dialogue will be very important. Last but not least, I'm jumping around here a little bit, but in terms of the G20, of course, what they are creating right now through Brazil as a use case is back in India, during the G20 presidency, there was a lot of talk around creating a global alliance for manufacturing to have better access, equitable access to vaccines, treatments, and diagnostics. Now Brazil has taken up this discussion again, and they're talking about how they can create a more basically better coordination between different regions and continents to not only create an alliance where they work with the pharma community to ensure equitable access, but they are also talking now increasingly to other agencies like HERA, like BARDA. How can there be a better collaboration, that there is a better supply chain mechanism between these institutions to create a stronger alliance for equitable access? So these are the discussions that are happening on the G20 and that we have been also partially driving. And I would just like us to use the EU as a use case, and with the new fiscal reform, and maybe try to create a new type of dialogue with the G20, because that's my last point. The critical thing is, with the WHO facing new financing challenges and with geopolitical elections happening, we don't know how much budgets will be left to the WHO, and the European Union will be playing a more critical role in promoting global health policies. And as you said, Margarida, the MFF, obviously multi-annual framework, is something groundbreaking that was recognized globally and in the G20. But how can we tell these stories a little bit better, how the EU is actually not only better investing in member states and trying to change these rules and reforms, but also there is a big portion of global health financing and ODI money going from the European Union to low and middle income countries. But these stories are not told efficiently. So how can we embed basically the EU more into these structural discussions globally is something we would like to obviously see and support. And last but not least, I keep saying it, for next year, there is a big momentum, for example, of the world's community, as you will know, is looking at non-communicable diseases. And we heard from our panelists that this is one of the biggest hurdles in our rich, high-income economies. So how can we use the UN high-level meeting next year in New York that will focus on non-communicable diseases to make the economic argument within member states, but also tapping or bringing them together with parliaments, and to show that an early investment into tackling or containing non-communicable diseases can have a long-term output in productivity growth and economic terms. So I leave it there. I tried to capture many of your points as the last speaker. Obviously, it's not easy to cover it all, but over to you for opening up the discussions. Thank you.
Thank you so much. Excellent. I mean, I just think from a European standpoint, if you think about one of our industries that is doing quite well, it's actually the health sort of industry and R&D. So I think it's very interesting to hear from you, Hatice, also how that in plays in the world and global leadership on health, I think, where Europeans, to my mind, should be quite strongly in the ring. I wanted to just see if there are questions from the audience. And I also want to see maybe if our panelists have reactions to each other's very interesting interventions. I see one question here. Oh, many questions. Please start. If you can briefly introduce yourself. I may repeat there's a microphone. That's even better. Then people online can hear you as well. Yeah,
Good.
Thank you.
I use the microphone. Annika Eberstein, I work for Philips. So coming from the medical technology perspective. So obviously, one of the major challenges that health systems are now facing is climate change. I mean, both in terms of impact, increased demand for emergency care due to floods, forest fires, and so on. But also, depending on the energy mix, health systems use 5 to 10% of total emissions of a country. So clearly, there's a lot of need for investment here in health systems themselves to decarbonize and become more environmentally friendly. But to be honest, there are commitments. I mean, the COPs are now, have a health day, and we do see momentum. The Netherlands has a Green Deal for the health system and so on. But when I look at some of the budgeting and financial rules, they are really from the 1950s. I mean, in the sense that we don't have any incentives right now. Certainly in our sector, there's no green public procurement, except in some countries like Sweden. And, we see some good examples, but it's definitely not across the entire European Union. And then we are not even talking about, introducing circular economy models, because hospitals cannot do that because they have budgeting rules that essentially focus on purchase of new equipment once instead of, thinking about shared ownership, refurbishment, and so on. So I mean, I don't know who should answer that, but I think there's a question here what the European Union maybe could do to use their fiscal and funding rules and programs to create more incentives there also for health systems.
Thank you so much. I'm wondering, I think maybe it's nice to just make a bit more of a dialogue. So then Dennis seems to have some thoughts on your very good question.
I think this is a really very important point, right? And to start to also measure not only the economic impacts, but the environmental and the social impacts, not only in the healthcare system, but also along the supply chains, because I described that you need to see it as a macroeconomic sector, right? And it's if it creates 10% of our wealth, then we do know that there are emissions, and why shouldn't we steer and give incentives to reduce it? It's the biggest sector, and we need to find ways, and then you can finance innovation as well, right? And yes, it's a super important topic.
I'll just add if I can. So we do a lot of thinking about this at OHE. We've got a webinar going out today, in fact, on this very topic. So do look it up. And just to say that I think there is a lot of discussion in this space. There's kind of two questions there, isn't there? Maybe that's the case. Well, obviously there's lots of questions, but part of the question is around incentives for health systems. The systems themselves, but also clinicians on the floor. Like, clinical decisions are really important. How clinical decisions affect length of stay, consumable use. There is huge scope for change, but it links back to how our health services are so underfunded. There's a lack of headspace, there's a lack of will, there's a lack of funding for actual change to happen. There's also a whole conversation around incentives for industry. There's a huge number of incentives that we could use: reputational, collaborative, regulation, market-based incentives. And what the conversation hasn't got to a point where we fully understand what the appropriate package of incentives is. And yeah, really interested to hear if anyone has any ideas on what the EU's role in that would be, because I agree with you, it's a very, very interesting conversation, and one that we have not made enough progress in yet, given the substantial contribution of the health sector.
Thanks so much. I saw at least two more questions here in the audience. Maybe we can go to the next one. Thank you.
Thank you. I'm Silvia Ganzerla from EuroHealthNet. I represent public health authorities from national and regional level. And we aim to achieve better health equity and health promotion in Europe, also beyond Europe, because we have members also outside European Union. What you said was really interesting for what we do on our day-to-day work. This issue of considering health as an investment that has a high returns in the end is a fundamental argument. Also the importance of addressing the socio-economic factors that are related to health. So looking at health in a global way. For us is also important, I've heard the concept of One Health, which is great. For us, we also talk about economy of well-being, which means taking together economy, social employment policy, and environment all together to improve the overall well-being of people. And this is something that at European level was strong during the Finnish presidency. It's still strong in certain member states, but we have a feeling that it has been a bit out of the discussions at the moment. So if you have any feedback on this concept of well-being economy as something that can be relevant at European level, and maybe even thinking about the European semester as a framework for delivering the economy of well-being. My second point is about the current political situations we are living in. You strengthen the importance of political commitment to investing in health. It looks like we have the data, we have the information, we have the evidence, but we are lacking political momentum at the moment. If you look at Ursula von der Leyen's program for the future commission, there was very little about health, maybe nothing about health promotion. We know that EU4Health has been cut by 20%. I don't know if there's a chance that the parliament would fight against it and any chance of winning and putting the money back, but it might be quite challenging. We know that there's a shift in policy priorities for defense, competition, helping Ukrainian people. We have nothing against it, but why health is where we are cutting public money when we have all the evidence that if you invest in health, you save money in the long term. So my question is, what can we do to bridge the gap, the knowledge gap between the researchers that are collecting evidence and the politicians that maybe have this short-term approach? Could we maybe think about having momentum every year, as someone mentioned, where we have these reflections at European level? Could we bring DG Employment, Santé, Agri, Environment, ECFIN all together to make the assessment of a national plan and to see to what extent member states are investing in health promotion instead of cutting? Because to be absolutely honest with you, we've seen in the past, when it comes to difficult times, health promotion is the first things that get cut. Because it's easy, nobody will complain in a way, and the impact will be in the long run. And this is something that we really fear that is coming next. Sorry for my long intervention. A mix of feedback, comments with some specific question for you. Thank you very much.
Excellent, thank you so much. I think Margarida had some reflections on your two broad points, I think, or three. So, and then I think I might just go back also to our online panelists who want to react to some of the questions that were asked.
Yes, I can support all your considerations, almost all the considerations you made in the beginning, because of course we know that sometimes there are a gap between the political goals, the trend, the speech, and how to act, how to work. And of course, I was in the Commission for 21 years before to be in the Parliament. And I know very well the House, and I think that you raised an important point. And now there are conditions to do it, clearly, because there are a new service in the Commission on the RRF national plans that is where there are a coordination of the different national plans and the different priorities, and health is one of the 6 priorities. So it means that this new service, this new DG, must work together with the sectorial DGs. So it means that there are a good moment, there are a momentum to do it in an interconnect approach in the House. But I'm no more in the Commission, and I don't want to give lessons, but of course, there are a momentum to do it. It's why in my first words, in the beginning, I said that maybe is the moment to understand how RRF and how MFF are contributing to increase the capacity of the national health systems to deliver. And I think that another argument was also launched by one speaker on the role of the EU at international level, including health politics. So this is a key moment where, if it was not done until now, there are conditions, I can say administrative conditions, burden conditions to go ahead on more coordination in the different approach. So this is bridge the gap on health. I think that the answer is DG must work together, and the coordination service for the RRF can have an important role. On the cut on the EU for health, as I said before, the Parliament demanded to increase the budget for the EU health program 4 times more. But when the revision was made, and I was also co-rapporteur because I was standing rapporteur for the MFF, co-rapporteur, the point was that as it was a program starting in the beginning of the MFF, this MFF, it means Erasmus, there are already an experience, Horizon, there are an experience, other programs, they had an experience before. It was only to go to follow up the previous experience. With the EU for Health, it was a program that started with this MFF. It seems, and the figures of the Commission that the Commission put on the table show it that the absorption of the EU for Health was not strong enough. So it means when the cuts were needed, normally is the money that it's not absorbed that are cut. This is how can I say, a tradition. So it's why it was so difficult to the Parliament to oppose to this cut on the EU for Health. It was not necessarily a cut. It means if there are some money coming to EU for Health, progressive, it's not a cut, it's on the year by year that there are a reduction. So this is a political argument, but finally, when we arrive 2027, it's a cut. But it was the position of the Parliament was against, of course, but it was very difficult because the absorption was too low. I need to add 2 other points. It means I can understand, and I fully agree with you, when you speak on the well-being of the people in One Health, so in a global approach. There are 2 different elements that are very important on that line. The first one is the fact that the new economic governance framework, there are a concrete article on the social convergence framework, and the health is inside the social. So it means that there are a key role that didn't exist before. Is a new article, is this social convergence framework. And the second one is in the European Pillar of Social Rights. As you know, on the European Pillar of Social Rights, also health is inside as a social rights, oriented with on the well-being of the people. Of course, we need to insist, we need to demand to EU institutions to use this instrument to improve the system and the social dimension of the European Union.
Thank you so much. I think there was one more question in the room. Octavia, maybe, oh, you have the microphone, perfect. Please go ahead, and there's a question online, so after your question I would return to our online speakers, and then for a closing round here. Please go ahead.
Thank you. My name's Richard Corbett. I also used to be a member of the European Parliament, where I led the UK Labour Party in the European Parliament. We've heard a very convincing case from all of you on the need to invest and the return that you get on that investment, and I've learned a lot. How far do you think this should be complemented by legislative action? There is an interesting debate in the UK at the moment about legislating to phase out tobacco completely over a period of time. There are debates elsewhere, many countries, on legislation to restrict the use of sugar in certain foodstuffs. How far should legislation be part of the strategy? How much of that could be done at European level?
Thank you so much. I think I would like to go back to Santiago with this excellent question. And then there was one online, which is a bit more technical, but linked more to the, in addition to legislation, more to the financing side. So the question was from Jelka Drašković, whether the Commission would utilize the reference trajectory for public finances to recommend specific areas of investment that member states should prioritize in their plans. So Santiago, please go ahead.
Mm-hmm. Yeah, thank you very much. Yeah, the reference trajectory assumes that there's no policy change. So in a sense, it just represents how things are at the moment. It's more or less later when member states present the draft national plans and we can discuss them with them, that we can actually suggest ideas or more give feedback on what they provide us, etc. So it's really when they give us the national plan that kind of discussion begins. And on this question, on the regulation, basically to give incentives for healthy behaviors, well, or in some case to forbid unhealthy behaviors. Of course, activities that have negative externalities like smoking, like sugar consumption, like fat consumption, are prime candidates for legislation. Given where I sit in the Commission, where I sit more on the fiscal side, I think it would have to really be my Santé colleagues that actually know more about whether this is an area where subsidiarity applies, or where the Commission or the EU should take the first steps. But certainly, as a health economist, you know, regulation to actually give the right incentives is something that I'm very attracted to. Thank you. Oh yeah, and the other thing that I would like to comment on was this first comment on climate change. So, I mean, again, I look more on my day-to-day job at all the fiscal issues, but of course the environmental efficiency of healthcare systems is very, very important. I do know that in Horizon Europe there are several initiatives to actually promote basically to green healthcare activities and to promote also the circular economy in these areas. I'm sure my colleagues from Santé, Environment and Clima know, but yeah, as far as I know, the EU is actually doing something about it. And I'm sure there's a conversation that will continue in the future because it's a very important area and it's a problem that is becoming more acute. Thank you. Yes, I think those were all the ones that I wanted to reply to. Thank you.
Excellent. Thank you so much. Hatice, any reflections from your side on these questions and comments?
Yeah, sure. I would like to touch on the 3 points as well. So first of all, on the planetary issues where health is embedded in. Within the G20, we're talking at the moment about the triple planetary challenges that health is a crucial part of. So that's biodiversity loss, pollution, and climate change as such. And it would be very helpful, for example, as these discussions continue, to look into how much into the existing climate change funds that we have in the EU, in other countries or regions, can we bring in the health component and tap into these funds? There's obviously, at the moment, basically everyone is territorial when it comes to when the health community wants to tap into the climate change community. But again, that bridge can be explained through new narrative creation through legislators as well. It's not mutually exclusive. It can just benefit each other. And I think we should look into the green fund in the European Union, how much of that, has a health component. Then on the second part on bridging the gap between policymakers and regulators. I mean, as I mentioned earlier, I think the key thing is to have this annual structured dialogue within the European Parliament or in parliaments. And by creating legislators' reports within Parliament and advocating towards those, Richard Corbett mentioned that earlier, I think we can empower legislators to develop these reports, like within the UK on tobacco. I mentioned antimicrobial resistance. How can we basically make sure that legislators across governments and parties work on the same goal to embed some of the policies into their legislation? And one other thing we've been working on, I posted that in the chat, is the good thing we've done in the climate change field is we have developed a green taxonomy. That's obviously easier to measure, or basically create a common tool where we speak the same language between investors and the health community or governments. But I think as a first step to look into more structured investments into health is, can we develop a common taxonomy for health investment? And can we break that down so we speak the same language across communities and sectors? And then we look into basically what gaps do exist in each country in the health investment space. And we can use this taxonomy to bring in new investment that is not only government related, but in a public-private partnership approach. So over to you.
Great, thank you so much. We're close to the end, so I'm just going to see one more time if this excellent panel has anything more to contribute or before I wrap up. Grace, please.
I can make one final comment. It's just a reflection on your question. Is that what I really like about your question is it reminds us, I think this is really important, that investing in health and all the benefits we expect to get from that is not just about investing in healthcare, and that there are it's a huge range of social determinants, one of which is smoking, which is being tackled by that legislation, that we need to be really mindful of and that we need to tackle as well. And it's not about plowing money into the healthcare system, although that does need to happen as well. So thank you.
One more question from the online audience. The question is to Santiago. I'll read it out. So in the UK and elsewhere, financial firms, in particular private equity firms, invest more and more in healthcare and care. And as is well documented, often extract excess profits from these investments. So far, competition authorities have been unable to deal with such rent seeking. How does the European Commission intend to deal with the fact that more investments in health end up in the pockets of private equity partners? Santiago, over to you.
Mm-hmm. Yes, no, so I mean, this is something that is really for my colleagues in DG Comp, who is basically the competition authority for the EU, and it's for them to look at what are excess profits, what is the investment in each area. From the point of view of looking at the fiscal sustainability of health systems, what we really care about is that people get the care that they need and that is good quality, accessible across society, and that this is done in the most efficient way possible. So in some way, these things would be could be inefficient potentially, these kind of behaviors that the person asking the question is describing, but tackling this really falls to DG Comp. Thank you.
Thank you so much. I have one takeaway myself because I'm a fiscal rules expert among some other things, but I've worked on it for 10 years. And one interesting blind spot that I realized I didn't have thanks to some of your intervention is, when we think of European fiscal rules, we say, oh, we leave out the cyclical dimension of unemployment, right, which is considered best practice. But in effect, if we think about some of these health-related unemployment pockets, then actually we're making an intellectual mistake, because there's some, a large group potentially. I think you mentioned some numbers, Grace, and so that these are like hundreds of thousands of people that in a way should be considered unnecessarily unemployed. And it's strange in a way that we don't see that as economists, right? So, but that's just one of many fascinating, I think, takeaways from this conversation. So I want to thank this excellent panel for being here, and WifOR for teaming up with us at CER, and MSD for supporting this event. So please, a warm round of applause for our panel. And for those who are here, we have some snacks and drinks outside. So, and for everyone online, thanks for joining us, and do reach out if you have further questions. Thank you.
Thank you so much. Lovely seeing you. Thank you.
Thank you. Bye.